Hello, everyone. I'm so glad you are here. I have an amazing guest, actually a repeat guest, because women wanted to hear more from Dr. Rosensweet. So I'm really excited to welcome Dr. Rosensweet back and to hear what he has to say today. But before we jump in, I'd like to introduce him. Dr. Rosensweet graduated from the University of Michigan. I'm from Minnesota, not Minnesota. University of Michigan Medical School. Side note, my husband went to University of Michigan too. In 1968, and since 1971, he has been in private medical practice with offices in Florida, New Mexico, California, and Colorado. Early in his career, Dr. Rosensweet trained the first nurse practitioners in the US and was in charge of health promotion for the state of New Mexico. He is nationally known lecturer and presenter at, to be honest, a lot of top-notch, high places that attract everyone that you'd want to have there. I'm not going to go through them all, but the list is very long. And in 2019, he was called to Washington to speak in front of the National Academies of Science, Engineering, and Medicine on the safety and efficacy of bioidentical hormones. So clearly, he is an expert in this field. He's also the founder of the Menopause Method and the Institute of Bioidentical Medicine, where he has been training medical professionals to master CBHRT, which he will tell you about, using the most advanced and modern tools. His protocol has been used to treat more than 12,000 women. Dr. Rosensweet, I could go on and on and on. The list is incredible, and that's exactly why I wanted to have you here. You are the expert, so welcome.
Thank you very much, Leah. It's an honor and a real fun possibility for me too to be here.
Well, and what I love about you, Dr. Rosensweet, is you bring the science, you bring the receipts, you have done the research, you've worked with thousands and thousands of women. You really do have a unique perspective in that not everyone in the menopause world is coming from a place of science-backed studies, has worked with that many women, and can really speak to what is working, what is not working, and where do you have to follow the science, and where does the science go into an area of being perhaps tweaked to fit a narrative, if I shall be nice.
That's happening.
So, what do you think the biggest controversy is for women over, 40-ish, entering that perimenopause, menopause state? What is the biggest controversy that they are faced with in social media, in the doctor's office, everywhere?
Well, I might have a different view than what's actually occurring out there recently in social media, as you and I were talking about. But the most universal trouble I find women have is that this event took place in medicine that I've never seen happen in any branch of medicine ever. There was women since the 1940s, millions of women were being treated in menopause routinely. In fact, 40% of all American women were on hormones who were in menopause. They were on Premarin or Prempro for the most part, and it was the most popular and profitable drug of all time. And the study was done on really with the intention I heard was to even support doctors in prescribing it for more women for more good reasons, like it was protecting of the cardiovascular system. So even expand from 18 million to 100 million because that would be appropriate.
Yeah.
But the study backfired. The study was poorly designed, but the real backfire was it was falsely reported.
Are you
In
referring to the
2002,
women's?
the Women's Health Initiative in 2002,
Mm.
they stopped the study and the press got a hold of it and blew up this firebomb that suggested that women on hormones were at greater risk for breast cancer, heart attack, and stroke. This is the worst thing. This never happened in medicine, where a common procedure all of a sudden got this much fear injected into it and was stopped, and 18 million American women went down to less than 2 million really quickly.
So 18 million Americans were taking hormone replacement therapy, and then that went down to 2 million
That's
in just
right.
overnight,
Just,
right?
just yeah, over, within 3, 4, 5, 6 months, it was down to 2 million. The consequences to those women, those are sometimes not paid attention to. They wound up losing their bones, losing their ability to think, losing their vaginas, winding up in assisted living facilities when they probably wouldn't have gone in there, or nursing homes just because of the loss of just because of that scare. And the problem with the scare was it was false. It was the opposite, is what's scientifically so. The scare was wrong. And the greatest book written on this is by an oncologist who's specialized in women with breast cancer. That was his specialty. This is
Mm.
a cancer doctor. It's called Estrogen Matters by Avram Blooming and Carol Tavris. And for people who really want to know the science, my God, there's 450 scientific references in there. It's well written, it's beautiful. Who do I recommend it to? Women who have had breast cancer and are really scared about getting hormone treatment, because they too should be treated. Now, in my book, which people can download for free, a PDF copy of it from your website, Happy Healthy Hormones, I devote chapter 3 to it because you asked the question, what's the biggest concern? In my experience, it's women showing up in an office knowing they need hormones. They're having so much trouble sleeping, thinking clearly, no longer wanting intimacy. They're losing, the list goes on and on and on. They know they need hormones, but they're frightened that they could get breast cancer. So
Yeah.
what I'd like to do is summarize the science.
Yes, please.
And then people could challenge me if they want, or read Estrogen Matters if they really want the full-blown science. We are all at risk, males and females, for thousands of medical diagnoses, and a lot of them are not good. They're hard to deal with. We're all at risk for hundreds of cancers, and those are not good. They're tough. Those are tough rides. And then, as a male, for example, I'm at a special increased relative risk for prostate cancer. And there's reasons for it. And they're modern reasons. The prevalence was never this high, but it's there. And women, turns out, as opposed to 50 years ago, the incidence of breast cancer has gone from, for example, 6% to 14%. Think about that. That's quite a leap. So women are at risk for breast cancer, and there's an increased relative risk, and there's reasons for that as well. But given all that, women who are treated with hormones are at less risk for breast cancer, heart attack, and stroke than women who are not treated. That's the science. To carry it a little bit further, women who have had breast cancer and have had that breast cancer properly treated, sometimes that's surgery, chemo, radiation, however it's been properly treated, they happen to be at an increased relative risk for recurrence than a brand new woman has at developing brand new breast cancer. There's a higher recurrence rate. However, given that, women who've had breast cancer and have had the breast cancer properly treated are at less risk for the recurrence if they're treated with hormones. And I could dive into the details of receptor sites, positive, negative, but the statement holds that no matter what the receptor site is, on and on, women who've had breast cancer properly treated are at less risk for recurrence if they're treated with hormones.
Okay, so just to break that down so I completely understand, I know a bunch of women are also probably a little confused here because we've heard one thing and you're saying another. A woman with a history of breast cancer comes into your office. She's menopausal, it's got a lot of symptoms related to perimenopause, menopause. And what would you say to her if she's really struggling and she's like, I've heard hormones will cause me to, my cancer to come back, or I can't take them because of my history with breast cancer. What do you say to that woman?
I say to them that it's really important that we know what the truth is for you.
Mm.
And we can walk that out until you know yes or no in your heart what's right for you as an individual. Because I don't want you applying hormones if you think it's going to give you an increased relative risk. This is not a great thing to do mentally or emotionally. And I also say this, and I promise you that to the extent that you want to and are willing to, if you dive into this subject, you will come out. You may be unclear now, but you're going to come out sooner or later with, oh my God, I know what the truth is for me. Whatever that truth is, honor it. The truth could be, no, I can't do it. I'm going to have to get adjusted to the symptoms. Or the truth for you might be, oh my goodness, I feel really good about taking them now. All the fear I had is gone because of all the research I did. Now, fortunately, the research path has been simplified down into one book.
The one you suggested earlier, Estrogen
Estrogen
Matters. Yeah.
Matters by
Yeah.
Dr. Avram Blooming. And I've summarized it and, added my own things in chapter 3 of Happy Healthy Hormones, which you can get for free. But if a woman will walk that process down, there'll come a point where each individual woman will know the truth for herself. She'll feel it. She'll feel it in her guts. If she was blurry and scared and unclear, there will come a moment if she does her due diligence where she will go, I know what the truth is for me. I'm going for it. You can never you can never say there's no risk. There is a risk of recurrence. And why? Because cancer has a lot of causes and a lifetime of them. And there are causes for cancer. They're not the hormones. The hormones aren't the causes. So that's how I would respond. Now, three-quarters of the women who've had breast cancer have shown up in my office. They've already done it. They've already come to the conclusion. Three-quarters or 80, 90%, because we are treating women with hormones who've had breast cancer. The bigger population is the woman who has not had breast cancer, but she's heard the fear. And
Mm.
this fear could have been dispelled right at the outset if true science. They even said within that study that scared everybody that women on Premarin alone, horse urine-derived estrogens, 50% of which the human female body have never seen, these women had a 0.79 relative risk. That means they had less risk for developing cancer, all these women on Premarin alone, than women who did not take Premarin. Right there at the moment they stopped the study, they knew that that number was 0.79. These women were better off, risk-wise, taking the Premarin. There was a number at that time, 2002, called 1.26. There was a slight increased risk for women who are on Prem-Pro. Premarin combined with a molecule that people on my medical board are not fans of, called Provera.
Mm.
They had a 1.26 relative risk in 2002. That's why they stopped the study. But what they stated in the study was that, and this was statistically insignificant, which means in science is don't draw any conclusions, folks. We don't know the final answer yet. But the press got a hold of that increased risk, exploded it, and except for the experts who paid attention to wait a minute. I heard the word statistically insignificant. I saw it right away. I said, why are they stopping the study? Because it was statistically insignificant. Now they followed these women. They continued to follow them. And the exact same study committee that scared everybody in 2017 published what I will call a retraction. They said after 18 years of follow-up, there is no increased risk from women being treated with these hormones.
Did
That was
that make
published in the same journal that they published. The original study committee published in the same journal, the Journal of the American Medical Association. Ooh, my, after 18 years of follow-up, there really wasn't an increased risk. How
Did
many
the
people have heard
retraction
of
make the
that?
headlines?
No.
So
No.
maybe that's not being talked about.
I don't know what percentage of doctors, if you interviewed, if you asked them, is there increased risk or not, they will not have been informed by that follow-up.
You know, you bring up a good point, Dr. Rosensweet. Like, I think you probably see a subset of, I'm guessing you see a subset of a population of women that have already been to another or two or three practitioners and either been dismissed or told you're just fine or just get through it. Um, and I kind of want to speak to those women right now that are going to their current practitioner and they're saying, you're fine, or like, we don't do hormones, or you don't need them, or there's no, the risk is outweighing the benefits. Can you speak to those women? Like, what you've already given some advice, like, go read these books. These are great tools and resources. Should these women be seeking out other doctors? What should they do? A lot of women are coming to me saying, like, this is my story.
Yeah, it's a great question. This is the essence, what it all boils down to, is once that news exploded all over the world, by the way, this just didn't happen in the United States. The fear was so great, and there's been who's got the antidote? Has the physician public, the nurse practitioner public, been informed of this? No. Here's insight into the life of healthcare providers. They are busy. They're working their butt off to get good at what they're doing in their lane. And they moved away from the whole hormone world. That was enough to scare them. And what they're exposed to is the knowledge of their particular endeavor. Endocrinologist, neurologist, blood pressure specialist, internal medicine. They're not privy to what's taking place in the background. They're still with that big fear that exploded all over the earth and affected women and healthcare providers, scared them. They don't want to hurt anybody.
Oh,
And the knowledge that they still have, because it has not been widespread antidoting, it has not been addressed. It's creeping in there. Dr. Blooming's out there giving lectures to hospitals. His book is out there. It's creeping in. Even some of the more popular people who work in this field, they're starting to get new information that, ooh, there's been a retraction here. It's creeping in. But the chance at this primitive time in human history, where consciousness is so compromised as it has always been, unfortunately, you can't just go to your doctor and expect that they've been informed of this. Because like you suggested, Leah, you said, well, hasn't this made it out into the public? No, even though it's published, no. And so we're in the era now for 22 years of trying to overcome this massive fear. The symptoms of debility that occurs for so many women in the perimenopause and menopause is enough to drive them. And this is the best advice I can give anybody. The reason I'm on this program with you is that I've done a very unusual thing in my medical career. I started specializing in treating women and men 30 years ago. And why I say that, because right out of the gate, I'm going, I've been 10 years prescribing hormones. I went, oh my God. And then I started reading into the study and I went, wait a minute, they don't even have a significant thing here. There's been hundreds of studies that have shown the benefit and the lessened risk. Why isn't this in perspective? And oh my God, the study design. There's so many flaws in it. Well, Dr. Blooming discusses the flaws in great detail. I didn't go into the level of discussing the flaws. So if the job of the woman, and I lost my train of thought there for a minute, the job of each individual woman is you have to go shopping. This is the most important thing I'm going to say on on our two times together. The job of each individual woman who's concerned is you got to go shopping for someone who really knows what they're doing. You're not going to get it from people who haven't devoted their careers to treating women in menopause with hormones, whether that's Premarin or bioidenticals. You're not going to get it from someone who, you want someone who said, wow, I have a tremendous interest in menopause and hormones. In fact, I've done a lot of studying and I've gone to a lot of seminars. You want someone who really cares about it and is publicly announcing that they consider themselves to be really good at this. You got to go shopping. And you'll find them. There's been so many people who've embraced this, and there are so many providers, thousands and thousands of medical providers, physicians, nurse practitioners, PAs, who do know what I'm talking about. It just hasn't hit mainstream yet. Thousands in the world of hundreds of thousands is a small percentage still. But if a woman goes shopping, she'll find someone that number one, she feels comfortable with, and number two, that they are declaring that they really care about hormones and they've done a lot of work and they're treating a lot of patients with hormones. And if you go shopping, just like you do for anything, you will find that person because they are in every state now. I mean, we've trained probably 1,000 at this point providers in our method. They're all over the United States and they're actually in other countries as well. There's other people out there training. So I assert that they're in your state. And here's how you go shopping. You start with your your friends. And for so many women, if they scan their friend base, there's going to be one of their friends who are on hormones. And you ask that friend, do you like your provider? Why, yes, I do. They're terrific. I had a great experience with them. You start there in your shopping tour. Here's another method. Connect with us. We've trained so many, we get, very often we can turn you on to someone that we've trained all over the United States. Here's another method. There are 7,500 compounding pharmacies in the United States. 99% of them, their main interest is in hormones. So what I recommend that you actually do is find one closest to you. There's three in the town that I live in. It's a small town. I live outside this very small town. And go in person to the compounding pharmacy. These are busy people. Why I say that you go in person, if they got someone standing at the counter that's asking a technician or a clerk, can I talk to your compounding pharmacist? That
Mm.
compounding pharmacist is 99 out of 100 times going to walk forward because there's an actual person. Not necessarily if you call them on the phone, but if you're standing there in their facility, they're going to be these are very interested, devoted people for the most part. They're some of the most devoted that I've actually met in my profession, but there's a lot of devoted people. They'll come around the counter and they'll be delighted to talk to you or make an
I bet.
appointment to talk to you.
Nice break in their day.
And then here's what you ask. That's right. They get to talk to a
Yeah, a
patient.
real person.
They're there for the patients, and now they get to talk to a patient. And you ask them this question. You're getting prescriptions from a lot of doctors in this area. Who would be your favorites? I'm in menopause. I need help. Who do you think's the most expert? These people, these pharmacists, they know. They've been in the field so long that they can tell when someone's a beginner, an intermediate, or an expert.
I love that you brought up shopping because for most women, that's something we're really good at. So, ladies, you got to go shopping, like Dr. Rosensweet said. And you gave us three great ways to do that. So, that's a great starting point. I do want to circle back to compounding pharmacies. You and I were talking about that earlier, and I shared with you that there was a well-known expert speaking about the fact that she didn't approve in the menopause world, didn't approve of compounding pharmacies because it's not FDA approved, it's not science backed. She had a couple other points, and I was wondering if you could speak to that because I think there's a lot of misinformation around compounding pharmacies.
In my humble, or shall we call it absolutely not humble opinion, who's ever spreading that rumor is wrong, way wrong.
Mm.
And I just want to give you my honest opinion about this. Um, Let me give you a little historical context. In 1993, I'm sitting there in my holistic medical practice, and in walks Deborah. She's in her mid 40s. This is a brilliant woman. She was able to retire in her mid 40s. Think about that. I knew her really well. She was really interested in her health. And she said to me, I'm going absolutely crazy. I can't believe it. Don't pretend you know me. I'm going crazy. And I happened to be speaking to someone, a world expert on progesterone, serendipitously. A couple of weeks before I gave her some progesterone, I get a letter from Deborah that, oh my God, this is amazing. I'm totally myself again. Well, that was a changing moment in my career. So I got really interested because I had never seen effectiveness like that. And also serendipitously, I had been talking to a compounding pharmacist a couple weeks before, and he was the one suggested, here, I'll make you up some progesterone. I went back to that compounding pharmacist. This is in 1993. I said, gee, I would go back to him when I would have a woman patient to get some advice from him. And I found her to be one of the most knowledgeable resources for me because he'd been preparing hormones for women and men for a decade prior to me meeting up with him. And I'm telling you a story that's very common. These compounding pharmacists have gotten really interested in this field, and you're going to find some of the best experts in the world of compounding pharmacists. Now, who are they? Pharmacy, an ancient profession. All pharmacists were compounders. All of them were taking basic ingredients and mixing them up and making individual prescriptions. And then this new thing happened where drug manufacturers stepped in, and for the most part, God bless their hearts. These people who wanted to become pharmacists, they're counting out pills. That's what they're doing. Not the compounding pharmacists. They're the ones who still have this brisk academic interest. They've got analytical equipment. They're held to standards they're some of the most regulated, controlled people on the planet Earth for good reason. There's been forces that want to get rid of them. So they keep tightening the controls on them, state and federal. Why? Because that 18 million to 2 million women, that change, the loss of that market share, and only to discover by pharmaceutical manufacturers that there was a return. In fact, a study in 2016 said there was now, from 2 million, there was now 6 million women in menopause being treated. And that study also said that over half of them were on compounded bioidentical hormones. And there has been a vendetta to get back market share. That's my humble, non-humble opinion. And there's been pressure on these compounders like the world of regulation has never seen. Well, I don't want to come to it from a negative angle. I want to return to the positive angle. These are the most interested of the pharmacists. They love making up individual prescriptions. This is a match made in heaven. Because let me tell you about women. I want to keep a special triggering possibility there. There's great individuality, woman to woman. How much each individual woman needs, how sensitive they are to anything you give them. Well, it's not a problem. All we have to do is individualize the individual patient. I could not function without being able to individualize dosages, ratios, what I'm giving a woman. I couldn't function without compounding pharmacists at the level that I want to function, or let me say, at the level that women want. Women want excellent medical care. When you go to a neurosurgeon, if should you never have to um, go to a neurosurgeon, but when someone goes to a nurse, they're going to want a really excellent neurosurgeon. When you go to someone breaks a bone, they're going to want a really excellent orthopedic surgeon. It's the stakes are very high there. They're out there, they're trained, they love it, they're great, they've got amazing training. In the world of hormones, you're going to want to have the most interested who have access to the best information. I assert you cannot individualize individual women unless you have the ability to write an individual prescription. And that's what these compounding pharmacies do. They receive an individual prescription from me. Now, I was messing around there. It is not the time to mess around in political incorrectness. The same is true for men. You can't practice good male medicine unless you're willing to individualize these men. There's a lot of moving parts. There's no difference there. But it's no problem for me. So I'm facing the world of what the pharmaceutical manufacturers had come with, 1 or 2 doses of Premarin at that time. 1 of 2 doses.
Wow. I mean, we've now entered a world where you bring up so many good points. Like women used to not even be included in studies about, the medical effectiveness of drugs or disease. And now we're finally being included. To your point, we are all bio-individual, all unique. And that brings me to the next probably topic I hear very commonly discussed among women is, like you said, women talk. We talk amongst each other. That's how we share a lot of information. And women are constantly asking their friends, well, what dose are you on? Well, what are you taking? Are you taking the patch, pellet? So maybe you can dive into the different ways that women can take hormones. Another controversial topic is whether you should get tested or not. There's a lot of controversy, or I should just say discussion around the perimenopause years. Should you get tested or should you not? And then types of ways of treating women, and then what that dose means and why the dose changes from woman to woman. Oh, that's a lot.
That's a lot. Let's take it on
Let
one subject.
me throw it all at you. Women want to know, Dr.
In
Rosensweet.
the world of absence of hormones, because midlife, we men and we women, we've lost our hormones,
Yeah.
and replenishing them really makes a difference. These are the most powerful biochemicals in our body. The consequences are what winds people up in assisted living facilities and nursing homes. 80% of the people in there are there from the ultimate consequences of low hormones. It really matters. And in the world of treating women with hormones, if you seek a health professional that's had a reasonable interest in it, almost anything they give is going to be beneficial. So I met many women who were on Premarin. They came to me. They were interested in bioidenticals. But what I noticed about the women who were on Premarin, let's say, for example, 20 years, they were doing much better than their compatriots. 1 or 2 doses of Premarin, not even doing progesterone in many cases, not doing testosterone and DHEA, which are critically important. These women were doing a lot better. So in the world of hormones, if you've got a reasonable provider who cares about it, almost any form that they give you is going to be beneficial. If you want to get really good, you go to an expert, and we're gonna have our opinions. And I'm going to have to break out the different hormones. Estrogen, by far the safest and most efficacious. I'm giving you an opinion. I can back it up scientifically, but you want to be taking estrogens topically, applied to the skin. Taking them orally is fraught with challenges that I go into detail in my book. The optimal, like I say, if the only thing I had was Premarin, I would prescribe it. I've never written a prescription for Premarin in my life. It's oral. It's an oral estrogen. But I've got wonderful options. So the best estrogen is topical. You apply it to your
A
skin.
lot of women are on a patch right now, so I'm assuming
And
that's
that's a patch. If that was the only tool I had, I would use it, but the compounded bioidenticals specified for an individual woman are very far superior. There's
Hmm.
issues with the patch. It's got glue in there.
Hmm.
There's other chemicals in that patch.
Hmm.
Chemicals is something we need to really take into consideration here. And you're only getting estradiol. That's only one of two really crucial. So the state of the art, and I discuss this in my book, young women don't have just estradiol. Estradiol is crucial. It's critical. It's the most potent estrogen that's put out by a woman's ovary. However, there's even a hormone that's produced in far more quantity in a young woman, menstruating woman. It's called estriol. And estradiol is proliferative, and it leads to the creation, it's part of the leads to the creation of the uterine lining that's shed every month. Proliferating phase the first 2 weeks of a menstrual cycle. It's also proliferating of breast glandular tissue. Every single cycle, a young woman is developing the possibility of getting pregnant, even down to breastfeeding begins right in the beginning. Women get new breast cells. Women can often feel their breasts get fuller as the cycle progresses. These are new cells, mitosis, cell division. If a woman does not get pregnant, these cells disappear by apoptosis. This is called deproliferation, and so does the uterine lining. It deproliferates and sheds. To start the whole amazing, you want to know God got us all that is, study the women's menstrual cycle. That's all it's going to take. Um, so estradiol is the main beautiful, gorgeous hormone that allows us to reproduce and actually create but it also triggers the onset of breast glandular cell proliferation. Estriol is the main stimulator of the deproliferation, and it's present in more than twice as much as the estradiol is
Hmm.
every single cycle.
So estrogen's like a symphony, the three that work,
Oh
two or three
boy.
that work together. And so if you're just giving estradiol, it's almost like you're doing a symphony without the strings, you know?
And you're exactly. And you're not honoring the importance of deproliferation.
Yeah.
Bottom line, and we don't know a lot of factors that relate to breast cancer risk. Well, isn't that amazing? We can't name them, but we can name a few. And one of those factors is increased breast density. That is not a healthy breast. In the old days, we used to call it fibrocystic breast disease. It's not healthy. And we don't want proliferation or increased breast density in midlife women. So the importance of estriol, and the only place that you can possibly get estriol is from a compounding pharmacy. So what do? We prescribe Bias topically. It has estradiol in it. Oh yeah, we love estradiol, but it has estriol in it as well. Biased. That's the best estrogen.
And I think you mentioned also that the cream, you're very conscientious about not putting chemicals in that cream because we talked about that being very important too.
We hold that to be very important. Like I say, I started out in the world where I was using topical estrogens and progesterone and testosterone, and they were in a gel called Carbapol. It's a gel. You can still get these gels, absolutely.
I'm afraid to ask.
Because in any container that has estrogen in it, or progesterone or testosterone, over 99% of it is actually what the estrogen is carried in. It has to be dissolved to give a precise dose each time you do it. If you have a toppy click or a clicking device that meets out the same dose every time, that estrogen has to be in solution. Well, these steroid hormones are very poorly soluble. Am I going too deep in the weeds here?
I think women want to know.
Okay. So 99% of what's in the little bottle that women get of these topical hormones is carrier. And the
Mm.
carrier to get things into solution are strong solvents. And I didn't know that. But 10 years, 15 years into treating women, my pharmacy, that I was prescribing all my hormones to, they would ship those hormones directly to the patient.
Mm.
I never saw a hormone for 10 years that I was prescribing. Then they misshipped one to my office instead of my patient, and I was fascinated. It came in a white cosmetic jar. It was sealed. I was fascinated. I got to see a hormone for the first time. I cracked the seal, opened up the lid, and out comes this really strong odor. And the odor was the solvent because it takes very strong solvents to get these things up into solution. So my son, one of my two wonderful, amazing partners in my team, we set to work to see if we could come up with something other than strong solvents. And there was even scientific literature on the quality of the solvents that were being used, that they were chemicals that we don't. And here I am, a functional medicine doctor for 30 years at that time, 25 years at that time. And I'm teaching people how to detoxify these chemicals and eliminate them from their household. And I'm asking my women patients to apply a quart a year.
But I'm sure that it was FDA approved solvent.
Well, yeah, it happens to
I'm
be
sorry,
used
I couldn't
in
help it.
FDA approval. Every compounding pharmacist buys hormones to prepare in different
Yeah,
methods that are FDA approved. The hormones themselves are FDA approved. They're produced
yeah,
in FDA approved facilities. Oh, people don't mention that.
yeah.
They just say they're not FDA approved. The combination are not approved, even though the most popular gel, that estradiol gel that's out there, that's in carbapol. All these years later, they copied what the compounding pharmacists had been doing for many years. That's a whole other story. But what I want to get back to, we finally developed an organic oil,
Mhm.
certified organic oil to deliver these hormones. For example, here's mine, my testosterone. And so our hormones, we have compounding pharmacists put in a certified organic oil. They are not a solution. There's no solvents in there. You have to shake the bottle before you use it. That's how I do it. This is my actual testosterone. I shake the bottle, turn it upside down with this oral syringe, draw it out, and apply it to my skin.
That's so important. I mean, if a woman's starting these hormones in even like let's say her 40s, she could potentially have half her life of applying these products to her body. And if you're putting, it might sound like a small thing, oh, it's just a one bottle, who cares, little solvent. But if you're looking at that over time, 40 to 50 years
Quart
of,
a year. It's a quart a year.
oh my gosh.
I did the math on it way back then. And like I say, everything in medicine is risk and benefit. I just don't want to add to the risk when I can help it.
Yeah.
And if the only thing I had still was my good old hormones and carbapol, I'd love them and embrace them and still be prescribing them. But there's good, better, best out there. And so what do women and men want?
Yeah. Well,
Best.
yeah, the best. And people like you are pushing that envelope forward. They're pushing the boundary forward. You're saying we can do better,
Yeah.
and more and more studies are coming out saying, can we do better for women? So I just love this. The movement is going in the right direction, being pushed by experts like you. So thank you for on behalf of all women.
My honor, and it's been the most exciting thing when I switched to specializing in treating women and men. It was the best choice I ever made my whole career.
I love
And
it.
thank you.
I love that you have given us tools to empower ourselves as women. Your book, the other book recommendation, Estrogen Matters. I love that you empower us with information here as the other experts are doing as well. And if there was one more thing you wanted to add to kind of, share
Well,
one
you
last
asked
thought.
another question. You asked
Yeah.
about testing. We
Oh, yeah,
test.
we didn't even get to testing.
There's a lot of questions.
So many
You know
questions.
why, Leah? To do it really well, it's a complex field.
Mm,
And the body of knowledge is complex. This turns out to be nothing to a medical care provider who spent their life, their careers devoted to acquiring information and tools and skills and being mentored, and then takes on hormones and they acquire that body of knowledge and they see their first 100 patients, they start getting good at 100 patients. It's nothing to them. It's fun. It's a sport. But to the just like automobiles, there was a time where I couldn't rebuild my own engines anymore. I didn't have the knowledge and the experience to do it, so I turned it over to a mechanic. Well, the same is true in this field. But testing, should I cover that, or is there any other?
I'm so glad you reminded me that we didn't even cover that, please. Yes, that's important.
We test 100% of women and men that we treat, but we do it at the right time,
You said 100%.
100%,
Wow.
and we test them annually.
Okay.
We want to know what their hormone levels are. We're treating them. Here's why we want to know what their hormone levels are. There's a rumor out there that all you have to do with a woman who's getting a lot of hot flashes and all kinds of symptoms is keep increasing her dose until her symptoms go away. You don't have to test them. One of the biggest authorities out there says don't test anybody. It's fraught with problems. It is fraught with problems, but not if you do it right. That's the whole thing. If you do it right, it's not fraught with problems. It's pretty easy. But symptom alleviation is not enough because we did a personal study. We do a lot of studies. And one of the things before speaking at one of those conferences you were talking about, every year I used to say, "What did I learn last year that's new?" I'm going to present it at the conference. So one year we looked at 54 of the women who during that year said to me, "Wow, I found my right dose. My symptoms are gone. I feel great." We did 24-hour urine hormone tests on them. I'll have more to say about that in a minute. And we learned that 50% of them were not on enough estrogen to protect their bones and their vagina, even though they felt great. It was a myth that all you have to do is alleviate symptoms. 50%.
Hmm.
25% were on doses a little too robust that could put them at risk for breast glandular cell proliferation. That means only 25% of them, even though they felt great, were in the zone. But it's no problem for a provider who tests. By the proper method, we tested when do we test? When a woman says to me, after, and it's usually at 3 to 6 months in the treatment process, she says, "Oh my God, I feel so good." We've done it. And 98% of women should have that experience sooner or later, 3 to 6 months. They should get dialed in to where they're saying, "Wow, I'm back to myself again." That's what we're listening for. We test 100% of women at that point.
So
And
you
we do
don't test initially when they come into your office.
well, let me tell you about initial. I,
Okay.
I used to test women initially, and I'm going to divide them into two groups. Those who are still having periods and those who they're not having periods. And I would ask the women to do the $340 24-hour urine. They come to me in menopause. They haven't had a period for a year, as an example. And I test them. And very quickly, I learned that, oh, guess what? Their ovarian hormone levels were zilch. And I gave them the privilege of dishing out $340 for me to be able to tell them that their hormone levels were low. My God, they weren't menstruating. Their hormone levels were low. Well, so I say to any woman who's no longer having a period, it's you're going to waste your money because what you're going to hear is, "Oh, your hormone levels are low."
Makes sense.
Now let's take the women in the perimenopause. When you look at the output of the ovary in a young, healthy, regularly menstruating woman, let's just take estrogen. It follows this exotic and, like you said, a phenomenally orchestrated pattern. In the beginning, when the woman's having her when she's actually menstruating, the estrogen level is low. Then it rises over the first 7 days, and by day 12, it's the highest it's going to go. And then it dips to about two-thirds of what it was, and then it rises again and falls back, and she menstruates again. Very beautiful, amazing, predictable pattern. Not so in the perimenopause. A woman's brain and her hypothalamus, so to speak, goes, "Whoa, these." I mean, a woman's peak hormones are, and a man's peak hormones are when we're 20, plus or minus a couple of years. They're the highest. Then they decline until we're 80, and they're zilch, 90. So here we got a woman in the perimenopause. She's already lost a certain percentage of her hormones, and her body and her brain has not caught up with evolution. It says, whoa, we want to keep reproduction going. And it puts out some powerful bursts of the stimulatory hormones coming out of the pituitary gland to stimulate the ovary to come back online. And you get these bursts. And you know what? The ovaries respond at first. But so instead of this nice smooth curve, you get this woo, but it can't keep it up, so it falls. So another burst comes out, can't keep it up, it falls, and it's erratic. And I describe this in detail in my book. So it totally depends on the day that you test the woman. Well, how did I learn this? I'm sitting in front of a woman patient. She's having hot flashes, night sweats. She can't sleep. Her mood is tanked. Her vagina is getting so dry she can't have intercourse. I am 100% certain that these are the premier uh, symptoms of low estrogens. Across the board, universal. I know it. She's got low estrogens. But I test her and I get a test report that says she's got high estrogens.
Mm.
And I say to her, I know you need estrogen. Must have caught you on the day when you had one of those peaks. And the woman looks at me like I'm nuts. She went to a medical doctor that's testing her and telling her she's got high estrogen levels on her test results, but wants to give her estrogens. You cannot test a woman in the perimenopause. You're at risk for giving her false information that confuses and confounds her and delays the time that she should be optimally starting the hormones, which is in the perimenopause.
Okay, I can totally understand now why experts don't test in that initial phase now. So then my next question is, I've heard that testing later is hard to read because every woman, we even talked about this, we're bio-individual. What woman might feel good on some dose if her test comes back at some level, another woman might feel crappy at a higher dose. So how do you navigate that? So you do start testing after you start treating. And then what do those results say? Do you have one number across the board for all women? Does it vary? Like, let's dive into that a little bit because that's confusing for us women going to the doctor.
Well, let me give you some numbers to plug into what you originally described there. How wide is that individuality? We have some women on, well, the bottom line of how much strength we give a woman in the world of estrogen. I'm going to throw out a number. It's 0.88. That's the low end. Some women are going to be totally satisfied with 0.88 and they're going to test properly. Other women need 4.8. Do the math. That is
Not my forte.
over 5 times as much.
Okay.
This woman actually to get symptoms alleviated needs 5 times as much as this woman. That's the range, and there is an average. That's the range you're talking about. And you know what? There's outliers that even need more than that. So your question is an excellent one. Well, one of the things I did, well, here's what you know is for certain. When you're giving a woman hormones and she comes in for a follow-up visit and she said, "Oh my God, I'm myself again. I'm no longer having hot flash. My vagina is healing. I no longer need lubrication. My brain fog, which was interfering with my professional life, I couldn't think clearly. It's cleared up." One thing you know, something good's happening there. You're in the ballpark. So I don't want to diminish the importance of dose titration. I just want to say it's not the final answer.
Got it.
And then one thing I did is I went into the medical literature to try and answer the very question you're asking. What's too little and what's too much? And there's great studies in there. And we actually defined it in the laboratory that we work with, the 24-hour urine hormone laboratory that we work with. The owner is a PhD who specializes only in steroid hormones. He agreed that what I had extracted from the medical literature was accurate, and he's willing to publish it. This is a scrupulous scientist who wouldn't let anything go by. He's invariable and inflexible in a very particular way. He wants the science. He's willing to publish what I took out of the medical literature is what's too little. Because we can get from the medical literature numbers where if you don't give a woman enough estrogen strength, she's going to continue to lose bone and she's going to get vaginal atrophy. That's defined in the medical literature. At the other end of the spectrum, what's too much? Whatever creates breast glandular proliferation. This number is known. So we define this optimal zone for treating women in menopause. If this is the range I was describing, 0.88 to 4.8 in young women, or in what it takes for a young woman, we're treating menopausal women right here, right below young woman levels. We don't want to get them into breast glandular cell proliferation, but there is a bottom there, and we define that bottom. We want to protect those bones and we want to protect the bones and the vagina because we know the numbers. Now, having said that, there are exceptions galore. Medicine, it turns out to have a complexity to it that's big fun for people who've devoted their careers to it. It entertains the living heck out of us for our whole lives. It seems complex to those who have, that's not their dharma, that's not their main thing. It is complex. It is that complex. There's a lot of moving parts. You got to pay attention to a lot of things to do really good work. But again, it's fun for those of us who take it on fully.
I think that's why they call it a practice, a medical practice,
There's
right?
a, there's a certain amount of practice going on.
It's an art that you're continuously refining and
Oh
learning
yeah,
and testing.
absolutely.
Yeah.
I say it took me 30 years to start getting good at stuff at this field. 30 years after graduation to start
Oh,
getting good
wow.
at it. Yeah. And I bet you there's a lot of doctors who would agree with me and a lot of nurse practitioners who would say the same. It took me 30 years to
Yeah.
really get good at what I'm doing. And but I want to go back to the testing. There are exceptions galore. The medical literature also showed me this. I wanted to define the bottom line of what's enough to also include protection of the arteries in the brain. And the medical literature says no way, that this range is much wider, that there's some women who will be taken back from brain fog, from cognitive challenge, from dementia, can be brought back into normal function, but some of them need really big dosages of estrogen to do it.
Wow.
So there's all these exceptions in medicine. You never say never. And I have a personal medical colleague. She's 65. She's a practicing physician. At 55, she was starting to lose her ability to think and remember patients, and she was terrified for several reasons. One is she was afraid she was no longer going to be able to practice medicine. She wasn't remembering her patients. She wasn't remembering their details. But the thing that was most frightening to her was that her mom had dementia and her mom's sister, thus her aunt, had dementia, full blown. And she knew where she was headed genetically, or there was a strong, because once she started losing her mind, she thought, why am I not going to wind up like my mother? But she knew the relationship of estrogen to brain function. There's a jillion estrogen receptor sites in the brain. And she started taking estrogen and she started to clear up a little bit. And she started to take some more estrogen and she started to clear up some more. And to shorten the story, she wound up taking quite a bit of estrogen and her brain cleared up. And I remember the day I had lunch with her at the age of 65 when she was telling me this story. And it turned out that she was taking so much estrogen, her period returned.
Oh, wow.
So you got to know the whole thing. You can't just say this is for every woman. There are exceptions, and we need to honor those exceptions. They're not common, but they're out there. So there's different things. How much does it take to protect the arteries? So we pay attention to all of it.
Well, I think
And
this loops back really well into how we started this conversation, and that when I asked about breast cancer, you said, each woman needs to find her own truth. And it sounds to me like the best advice is for women to go to an expert in hormone treatment and have this conversation. Also, do your research And you get to weigh the risk and benefits because, like you said, there's always risks and benefits to everything in medicine. And your example of that story of that woman, the doctor who started taking, I'm assuming, higher than normal amounts of estrogen, another doctor might have said, no, your risk for breast cancer is too high, don't go there. But she educated herself. She was very educated already, but like, I'm saying she weighed the risk and the benefits and realized that I don't want dementia. Like that's a huge risk. And so she went on her own individual path to figure out what was right for her. You tied that all together so nicely.
Which brings it back to what's the job of each individual woman in the perimenopause? It's to go shopping. People are diminished or criticized for shopping. My God, it's a phenomenal process. What happens to those who shop? You'll wind up with the best stuff, no matter what it is. If you put your time in to investigating these pair of shoes or that pair of shoes or this automobile or that automobile, those who do are great shoppers wind up with the very best stuff, no matter what it is. And it needs to be done in medicine. And so I say that every woman's job is because you're going to need a professional and you're going to want someone who really knows what they're doing and is to go shopping and find someone, number one, that you see their credentials and they're a medical doctor, they're a nurse practitioner, or they're a PA working under a really savvy medical doctor, or they're an advising clinical compounding pharmacist who's also involved in treatment. That can be done in some states. They love this stuff and they've taken on the educational process because we don't learn this in medical school. We are not taught this. We're not taught this in gynecology residencies. We are taught this. I'm not a gynecologist. I'm a general practitioner. But man, if I put in the time and energy to learn, the resources are there. We're a source of it. That's what the main thing I do is I teach and mentor physicians and nurse practitioners. So for any providers out there, contact us. I say we're the top of the mountain. I'm not a humble fellow particularly. But if you find someone who really loves the work, has gotten some ongoing training, and you like them, you like how they operate, they're going to talk to you. They're going to spend time with you. They want to deal with you as an individual. They're trying to understand. That's where the best medicine is practiced. I was telling someone the other day, I was telling a group of the students that I was teaching, I was saying, look, you're going to walk into many consultations. Is it all right that I keep going on and on here?
Absolutely.
I told the students that I was talking to, I said, you're going to walk into many consultations and you're going to hear the patient's story and you're not going to know what's going on. You're
Mhm.
going to be you're going to draw this big blank. What is going on here? But here's what I promise you. If you keep listening and you keep asking questions, the minimal thing that's going to happen to you is you're going to have a light bulb moment where you know what the next step is. You know the exact right thing to do the next step in practice. Come up with an idea, you deploy the idea, you see how it plays out the next day or the next week. So what I'm saying is that if you've got someone who's really interested and is willing to put in the due diligence and time and really get to go with the individual, I assert to my students that there is never a case that you will not eventually figure out. Just pay attention and keep inquiring. And you got the tools, you'll figure it out. So you want someone who preferably is specializing in hormones. You getting a little hint here that there's a lot of moving parts here. And that's if they just pay attention and they do the dance with you. In the beginning of my career, Leah, I know almost nothing. There was almost nothing known. I had a few mentors that I could turn to, but I figured out this. I said, I'm going to teach my women patients a certain thing about the symptoms. I'm going to start with the low doses, and we're going to team this. We're going to figure this out together. I had no other recourse because I didn't know enough. And that's what I learned right out of the gate. If you sit down with the individual and you team with the individual, It's a wonderful sport, and women get to become experts on their own body because these hormones are going into your body, and you get to feel them as well. So again, go shopping, find someone that you like and trust, that's got a manner, that they're going to figure this out with you. Everyone knows this. I sat in a urologist's office once, and within 5 minutes, I could tell this urologist was top of the mountain
Mm.
just by his manner, just by his presence. And I was correct. He was. I didn't know that beforehand. So
I'm re
your intuition will tell you, I feel comfortable with this person. I'm excited about embarking on this process, no matter where it leads. Or, I think it's time to go shop, continue my shopping. This is not
next door.
Yeah, this is not the best automobile. I'm not feeling good about this automobile. This is not the right provider. You'll find your way to that because
Yeah.
there's so many out there. And in these days of telemedicine, all you need to do is find a provider that is good in your state, that's
Yeah.
licensed in your state. Because this is another thing about menopause medicine. 100% of it can be done with great excellence through Zoom,
Yeah.
through video conferencing. Yes, you need to see someone once a year because of a controlled substance issue, and that's not even been decided upon. You may not even, and yes, if you've got other medical conditions, there's doctors you're going to need to see in person, but you don't need to see someone in person if you're in menopause or andropause. You do need to have a urologist if you're a male or a gynecologist. Absolutely, you do. That's part of the contract we sign. I take on a patient when they have a primary care provider that can handle all the stuff that is outside menopause. But that's what I'm really trying to say is you got access to all you need is one expert in your state. And there's probably 20 or
Yeah.
50, depending on what state you're on.
I'm so glad you bring up this topic because, in general, women sometimes are scared to, we're sitting in front of an authoritarian figure, a medical doctor. For many women, this is an authoritative figure that we sometimes don't want to question or don't want to offend and go shop around, as you say. But you bring up such a good point that you it's also about how you are interacting with that practitioner and if they are showing interest in really hearing your story and hearing you. Women are getting dismissed a lot these days, so it's okay to go shop around. I'm glad that you gave that permission to women and just women everywhere. We
But
need
let me
to,
interrupt you for 1 minute.
yeah,
You
go ahead.
made a very important thing. One of your criteria should be, I feel comfortable.
Yeah,
And there are so many great doctors and nurse practitioners out there. They're not as common as they used to be, but they're out there. And what are they like? They're friendly.
yeah,
They're curious,
and
and you're going to feel comfortable. And you're not going to feel like, oh my God, I can't open my mouth here. I'm afraid of what's going to happen to me here. That's one of your criteria. If a woman bumps into that level where she's not comfortable, like she's talking to a friend of hers, or at least someone that she respects and then knows is basically kind, that's one of your criteria. Keep shopping.
absolutely.
That's why I wanted to interrupt you. That's such an important point you brought up there. You should not feel intimidated. You should, because a good healthcare provider, you're going to like them. You're going to feel comfortable with them. You're
Yeah.
going to feel like, God, this could be a friend of mine.
And you're most likely going to be working with this person for decades to come. So you
That's
better
right.
like them and feel comfortable with
That's
them.
why the shopping process is so important. Maybe you'll hit it in the first year. You'll get your optimal provider. So I'm so glad
Yeah,
that we get
I
to
mean, that will
focus
be
on
great.
when the rubber hits the road, it's shopping.
Well, I know after this, conversation with you, many women will probably want to work with you. I know you're only one person and there's thousands, tens of thousands of us. So I want to bring the attention of everyone listening that you have something on your website that can help you find a provider that's been trained properly And so they can go to your website. Where else could they? You said the pharmacist. I'm sorry, I forgot about that great idea you had. Go to the compounding pharmacy, talk to the pharmacist, and definitely talk to your friends. And I think the bottom line is find someone that you like, you trust, you feel comfortable with, and will listen to you.
And there's no
Did I miss
medical
anything?
urgency. Uh, No, you really summarized it beautifully. And there's no emergency situation here. You may feel in duress, and that's not pleasant, and it's driving you to seek someone out. But I promise you, if it took you 6 months, even under your current state of duress, it's better to find someone you're comfortable with. I'm not saying it's going to take you 6 months,
Yeah.
but there is no, like someone's got a high blood pressure, they don't have 6 months. If they got super high blood pressure and they're getting headaches, they got to solve that. You're heading in the territory of emergency room. You better find someone fast. As one example, if someone's having a convulsion, you got to do something fast. This is
Yeah.
not true about menopause and andropause. You can take the time, even though you're uncomfortable, to get the choice of your provider right, because medically you're not going to be harmed. Nothing bad's going to happen. You'll continue to lose night's sleep maybe, and you'll continue to have a mood, but it's worth doing the due diligence. But you're not getting harmed. You're not in jeopardy. This is a slow-moving train.
Yeah.
So,
So you've empowered us in so many ways, and I want to remind everyone listening to go get your book, The Happy Healthy Hormones. There's a link that I'll provide everyone and empower yourself. Ladies, it's time to reclaim your power. Educate yourself. Take steps in the right direction. Shop around. You have the all the tools here we've just talked about to help you feel amazing again. So don't settle for less. Those are my 2 cents. Any last words from you, Dr. Rosensweet?
yeah, I have a wide variety of women and men patients, and I've come to recognize that there's a certain number of women that they're scientists at heart and they want to know a whole lot, and they're fun. They're often the best compliers. And yet I still assert that you only have one. There's a lot of women, they've got busy lives, they got their own lane. They want to rightfully so find someone who knows what they're doing and let them continue their good work. So I don't want to make it sound like you got to learn a lot. You don't. You have one job, one core job. It's going shopping and finding the correct provider. It's just like me and my auto mechanic. I sometimes bring my car in there and they fix it and they want to tell me what they've done. I said, you don't have to do that. I like you. I trust you. I
Does
don't
it
need
work?
to go down this, even though I have an interest in it. So
Yeah,
I don't want to make it sound like there's a tremendous amount for you to learn, but you are mentioning something there, Leah, that sometimes you do need to learn a lot because you haven't found the provider who knows a lot. So you want to be an active part of your process. So read my book. That's you'll learn how to be, you'll learn what's yours to do in that process. And there are some details to dial it in for what's optimal for your body. And you can become a very active part of the whole process. But
absolutely.
again, the main job is find someone you like and you trust and leave the driving to us.
Thank you so much, Dr. Rosensweet. I know many women go back and listen to this again. There was a lot of information, really good stuff. So I really appreciate all the time you've given us. Thank you.
My honor, my pleasure.